When you hear named murmur, don't memorize the name alone. The real clinical skill is to connect the sound with the lesion. Always ask, what is the timing? Where is it loudest? And what maneuver changes it? Let's review the first murmur. Carey Coombs murmur. This is a short mid-diastolic murmur, best heard at the apex. It occurs in active rheumatic carditis, where the mitral valve leaflets are inflamed. It may resemble mitral stenosis, but it is not fixed obstruction. The key pearl is no opening snap. Think inflammation, not true mitral stenosis. Now the second one, Steell murmur. This is an early diastolic, high-pitched, blowing decrescendo murmur. It represents pulmonary regurgitation due to pulmonary hypertension and is best heard at the left upper sternal border, the pulmonary area. So when you hear this eponym, think of severe pulmonary hypertension. Next is Flint murmur, a classic postgraduate favorite. It is a low-pitched mid to late diastolic rumble at the apex in severe aortic regurgitation. The regurgitant aortic jet strikes the anterior mitral leaflet and creates functional mitral inflow obstruction. It mimics mitral stenosis, but the mitral valve is not truly stenosed. Now comes Rivero-Carvallo sign. Remember, this is not a separate murmur. It is a bedside sign. In tricuspid regurgitation, the hollow systolic murmur becomes louder with inspiration. Why? Because inspiration increases venous return to the right heart, so tricuspid regurgitant flow increases. This helps distinguish TR from MR. Next, Gibson's murmur. This is the continuous machinery murmur of patent ductus arteriosus. It is heard in both systole and diastole because the aorta to pulmonary artery pressure gradient persists throughout the cardiac cycle. Classically, it is best heard in the left infraclavicular or left upper sternal region. Now, a quick bonus round. Steell's murmur is an innocent musical or vibratory systolic murmur, usually heard in children. Rogers' murmur is the loud, harsh pansystolic murmur of a small, restrictive VSD, often with a thrill. Gallavardin phenomenon occurs in aortic stenosis. Its high-frequency component is heard at the apex and may mimic mitral regurgitation. For rapid comparison, Carey Coombs and Flint are both diastolic and apical, but Carey Coombs suggests active rheumatic carditis, while Flint suggests severe aortic regurgitation. Steell is early diastolic at the pulmonary area. Rivero-Carvallo points to TR louder on inspiration. Gibson is continuous, so think PDA. Final approach. First decide the timing, systolic, diastolic, or continuous. Then localize the site, check radiation, and test maneuvers such as inspiration or posture. Finally, match it with the clinical context and confirm with echocardiography. Timing plus site plus maneuver turns a sound into a diagnosis.